Welcome. Thank you for spending time with us this evening for this interactive webcast sponsored by Intersect ENT. I'm Samer Fakhri, and to my right is David Conley. And we're live from Houston, Texas, and we welcome all the registrants from all over the world. This event is interactive, so there will be some polling questions that will be showing up on the right-hand side of the screen. Please feel free to answer them as we go along, and also you will have the opportunity to ask questions either throughout the webcast or at the end.
Thank you, Samer. It's a real honor to be here. We're going to talk about the big picture and some of the details in chronic sinusitis today. And my question is, with this analogy, what do icebergs and chronic sinusitis have in common? And if we think about this analogy, what we really know in chronic sinusitis are the patient's symptoms. That's what's on top, that's what we see, and that's what we treat. That's what really matters. But beneath that are a whole lot of clues as to what might be going on. And we use some of these clinically and use some of these in science. Now, endoscopically, we can see things like polyps and pus and edema. And with CAT scans, we can see the anatomy throughout the entire sinus system. But we know that the basic definition of sinusitis, which is chronic inflammation, is really driven by the inflammatory cells and the cytokines and the epithelium. And that's really down deep, and we don't really get to use that very frequently in our clinical work. If sinusitis isn't complicated enough in that regards, even the parts we can see are complicated. And we know that it's a multifactorial disorder. And some people have chronic sinusitis with just focal disease. Other people have sinusitis with osteogenesis. We have hyperplastic disease and polyps and even fungal pathology in some patients. Now, if we look deeper scientifically, we can find that there's a number of cellular observations. Now, a lot has been made of eosinophils in the last 15 to 20 years, and they do have some correlation with disease severity, likelihood of polyps to recur, as well as a refractory nature of sinusitis. But if we look microscopically, any number of inflammatory cells are present. And not only are the inflammatory cells present, but there are a number of cellular and molecular observations that start to come into a focus. Now, we know that there are a number of pathogens. They interact with the epithelium. And in addition, we have this whole dysfunctional inflammatory response below the surface. And we know that this is what drives sinusitis, but we're unable to really use this in a clinical way to make decisions. So when we think about what we're treating, I think very simply, pathogenesis falls probably into two general processes. One would be an acquired focal process. This may be obstructive. This is the one I think we all grew up with. It's very easy to understand. But there's also a diffuse mucosal process, such as in very hyperplastic disease or in patients with polyps. And these patients seem to behave differently. Truthfully, I think most patients are kind of a mixture of these two groups, and those probably comprise the majority of what we see in the clinic. But if you had to put patients into these two kind of phenotypes or at two ends of a spectrum, we have on one hand people who have chronic sinusitis without polyps. They suffer repetitive acute events. These are painful. They feel pressure. They respond to acute intervention. And it may be that there's a focal obstructive process at play there. On the other end of the spectrum are patients with massive nasal polyps. And these patients just have gradual progression of symptoms, typically congestion, stuffiness, and olfactory loss, not so much pain. And they have this diffuse mucosal inflammation. So when we think about treating patients with chronic sinusitis, we can ask the question, how well does our understanding of chronic sinusitis kind of correlate with our treatment paradigm as it is now? And what are the theoretical goals of surgical treatment? Now, when I was a resident, the theoretical goal of surgery for chronic sinusitis was just to ventilate the obstructed sinuses. It was pretty straightforward, and I think it was an easy concept to understand. But over time, our concept of this treatment effect has evolved, and I think we now know that treatment with surgery also debrides or removes the inflamed tissue. And certainly in patients with very hyperplastic and polyp disease, we know that all that dysfunctional epithelium is actually driving the chronic sinusitis. It's driving the inflammatory process. So removing that helps because it gets some of the machinery out of there that produces the inflammation. More recently, I think we understand that a big goal of surgery is just to provide access for topical agents or topical therapy. So we're just making access for delivering the medications to this chronic illness. Now, in chronic sinusitis, we're treating an inflammatory condition with surgery, which is traumatic. And indeed, inflammation is the body's response to injury. And so we have patients who already have a level of inflammation present, and we're adding insult to injury in these patients. And I think that the reason we struggle with some of our patients in terms of getting a good result and getting them to heal and resolve is that this inflammation is present. And what we would like to do is we would like to control or limit that inflammation, not only the existing inflammation, but also the inflammation that we confer during surgery, and in controlling that help improve the wound healing. Samer, what kind of options do you see presently for us to control this inflammation and chronic sinusitis after sinus surgery?
Well, we are, stuck with the two traditional, really, modalities. And I say that unfortunately because although our understanding kind of has evolved with chronic rhinosinusitis, but we really have not found a groundbreaking treatment for it. There's no major targeted therapeutic. So we're really stuck with the traditional modalities that we trained with, and that is one category is antimicrobial therapy, and the other category is steroids. If we look at antimicrobial therapy as a standalone treatment for inflammation in chronic rhinosinusitis, especially in the postoperative period, and when you look at the data regarding antimicrobials, it's really not very highly supportive of strong efficacy of that particular modality. So we're stuck really with the steroids, and that's quite unfortunate because steroids are so effective clinically only because they inhibit so many of those inflammatory cascade across all the pathogenetic mechanisms of chronic rhinosinusitis. So it's really a blanket treatment that suppresses inflammation. And if we look at steroids, there are different routes of administration. We're, of course, very familiar with oral administration of steroids as well as intramuscular, of course, to a lesser degree. We don't use intravenous for chronic rhinosinusitis. And the other category is topical steroids. So we're very familiar, I think all of us, people in the audience, are familiar with the use of systemic steroids in chronic rhinosinusitis. And there's no doubt that based on the studies and based on our experience, they are very effective in chronic rhinosinusitis, especially with inflammatory eosinophilic features. And the reason for that is that they start by working at the level of the bone marrow, suppressing inflammation there with the eosinophils and inflammatory cytokines later on. And they also have a more uniform reach in the sinonasal cavity and are quite effective in eosinophilic chronic rhinosinusitis. And if you look at these slides, these endoscopic views on the top one is a patient that I've operated that has allergic fungal rhinosinusitis and presented with an eosinophilic flare-up. And that patient, that was many years back, probably when I started my practice, and that patient was treated with a burst and taper of prednisone over 2 to 3 weeks, and you can see the results in the lower endoscopic view. Phenomenal result, and the mucosa regresses back to normal and becomes healthy. So, if systemic steroids did not really have these adverse side effects, it will be used uniformly on all patients. We may put it in the water in southeastern Texas. Everyone has nasal polyps. But it is unfortunately associated with a lot of adverse effects. Short-term use, chronic use leading to osteoporosis, exacerbating of pre-existing condition with a short-term use, and of course, withdrawal of use when not tapered properly after a prolonged treatment. So the question is that do we have, knowing that steroids are really the most effective and cornerstone therapy in the treatment, do we have a way of introducing these steroids where they need to go in a safe and effective manner? And of course, there have been emphasis on the use of topical therapy over the last decade. And that brings us to the non-standard, or we call high-dose topical steroids in chronic rhinosinusitis. And these are some of the clinical scenarios where I use that modality. I use it in postoperative maintenance in patients that have had surgery and want to control inflammation postoperatively. Treatment of mild eosinophilic exacerbations whereby the patients have been doing well, they have some mild symptoms, the endoscopic findings are mild, and it does not necessitate further heavy therapy such as systemic steroids. And of course now a placement after endoscopic sinus surgery to improve postoperative mucosal healing. When I look at the non-standard or high-dose steroids, I divide them into two main categories, and that have to do really with the delivery method. One of them is patient-administered. This is what you prescribe to your patient, what they do at home, nasal sprays, drops, irrigation, nebulization, and others. And the second category is physician-administered. That's what we do, us as physicians, in the operating room and in the clinic by instilling the medication in their sinonasal cavity. And these are listed here: steroid injected into packing, steroid-releasing implants more recently. I think many of you in the audience are familiar with the budesonide nasal irrigations and others. This is patient-administered therapy whereby the respules are placed in the sinus bottle or a nasal irrigant and then flushed into the nose. And there have been some studies to support the use of this in terms of safety and effectiveness, although it's not very high level of evidence. Many of you probably use, other than budesonide, there's fluticasone, propionate, high doses, and others. The problem with this category of patient-administered delivery is that it has some limitations, and one of them is that you don't know if your patient is really compliant with therapy and using this in a regular fashion. It is difficult to direct it towards inflamed mucosa. Remember, this is relying on the patient irrigating their nose, and from studies that we've done and others, we know that this does not necessarily get deep penetration into areas such as the frontal sinus or deep into the ethmoid sinuses, and therefore have suboptimal distribution. So that leads us to the second category, which is the physician-administered delivery of medication. And back when I started, many years back, we did not have any of these forms of high-dose topical therapy, and the patients used to come to my clinic, and when I see a patient such as what you see on the left-hand panel with that endoscopic view into the left maxillary sinus, you can see some polypoid edema. I used to basically put a 3 cc syringe, get some dexamethasone or what's injected in the ear, put on a cannula on it, and kind of put it in the sinus, of course the maxillary or the sphenoid sinuses, which can retain that fluid. And you can see in that one particular patient 1 week later. You can also, and we have used traditionally, some packing that you inject with steroids and you put it in the ethmoid cavity, be it after ethmoidectomy, after surgery, which I have used routinely, or during mild exacerbations or exacerbations when the patients come to your office, then you put a pack and you inject it with some steroids. And that was used by many of us until really more recently the steroid-eluting implant came to the market. And this is really, from a conceptual perspective, this is the long-awaited answer to the shortcomings of using systemic steroids on a long-term basis, or even the ineffectiveness of the other topical modalities. And when you look at the Propel, which is the prototype implant, it has 370 micrograms of memetosone furoate, which is a pretty good dose, and it's delivered over 30 days. It is placed in the ethmoid cavity. As it releases steroids, it is also has a stenting function to the middle turbinate, and it's made of a bioabsorbable polymer, and you can see it here on the right-hand side. And what's exciting about this also, other than its characteristics and the time release and all that, is that this is really the first one that is supported, the first topical therapy that is supported by level 1A evidence showing benefit of steroid release in post-ESS patient. And there have been many studies that looked at it, including a meta-analysis pooling 2 different studies. This is a slide, and I think it's important that we look at this. This is the primary outcome measures of using the Propel sinus implant in controls that you see here in black bar graph, and the treatment group that you see in gray. And if you look at the outcome measures studied, there was statistically significant decrease in each one of them, including postoperative interventions, surgical intervention, oral steroid intervention, and frank polyps. And if you look at other outcome measures also that were studied that had middle turbinate lateralization, significant adhesions. Both of these were statistically significantly decreased compared to the control group. So very good outcome data. And of course, if you want to go back to the analogy of the iceberg, we're looking here at objective data. What matters really are the patient's symptoms. And there have been studies that looked and showed correlation between these, also an improvement of the patient's quality of life measures, including SNOT-22 points. This is a video, many of you probably are familiar with it, showing the insertion of the Propel sinus implant in a right sinonasal cavity following endoscopic sinus surgery. You can see the ethmoid cavity. I've dissected it there. The middle turbinate is sitting in a medial position. The device is introduced. The implant is released, gently leaning against the skull base. And the ideal positioning is to have it open and the spokes to be opposed to the mucosal lining. You can see you can maneuver it a little bit so that you can push it against the lateral surface of the middle turbinate. And this is in another patient. I used the mini Propel in this case, and you can see a left sinonasal cavity. You can see the implant still there. You can see into the sinus cavity, the frontal sinus, the ethmoid, the middle turbinate is sitting in a nice medial position, a little bit of crusting, but overall, when you look at the mucosa, it has a very appropriate and healthy mucosal stage. So I'm going to use a case here, one of my cases, to illustrate a little bit of actually, you know, how I evolved using the high-dose topical therapy, especially what led me to using the implant, the Propel, in these patients. So this is a 60-year-old female with chronic rhinosinusitis with nasal polyps. You can look at the CT scan, and you can see she has had multiple surgery elsewhere before. She transiently improved. She continues to have symptoms, and she was refractory to medical therapy. You can see she has symmetric disease, polyposis, both in the ethmoids and maxillary sinuses. So this patient was a candidate for revision endoscopic sinus surgery, and this was early on when I started using the Propel implant, and I can confess that I did my little controlled experiments and in few of these patients, telling them so before the surgery. And I did put what I traditionally did, which is a packing on one side and injected it with triamcinolone with some steroids, and on the other side I did put the Propel implant. And in the next slide, what you will see is the right-hand side, where about 2 to 3 weeks after surgery, where the packing injected with triamcinolone was injected, and you can see the cavity. It is open, but it doesn't look that great. There's some polypoid edema, and you can see some of the packing that remains in the ethmoid and the frontal recess. In the same patient, on the other side, and this is the left side, you can see that the cavity looks very different, and you can see the mini Propel placed into that ethmoid cavity. You can see the mucosal stage looks much healthier than on the right side. This is a patient with symmetric disease that have had the same surgery on both sides, and one side looks a whole lot better than the other. And that was really intriguing to me, and I have a couple other patients that have similar results. And David, I mean, this is a pretty amazing result in terms of the contrast between these two. Any insight why this could be happening?
Well, that's a good question, and I think it is hard initially to imagine why the side with triamcinolone looks so much more hyperplastic and why the side with the Propel implant looks so good. But if you think about it, it's not that surprising because it has to do with the steroid. All steroids are not created equally, and steroids like Kenalog have a more more water-soluble property. They flash through the tissue more quickly, and they have a lower binding to the receptor, whereas Propel, which is coated with a time-release mometasone, is very lipophilic. And we know that that lipophilic nature, that fat-soluble nature of the steroid, allows it to be deposited in the epithelium, and it actually remains there for many weeks. In animal studies, 6 to 8 weeks. And so you get a higher binding to the receptor, and this kind of allows it to persist in the area, whereas other steroids flash through. And I think if you look at this little chart here, you can see that well-engineered steroid like mometasone is very lipophilic and very highly binding to the receptor, and that makes it quite different than something like triamcinolone. It makes it a lot more long-lasting. So I guess I would ask the question at this point, how can we really minimize failures after FESS? And I think we have to go back to the iceberg analogy and remember that what's on top, the tip of the iceberg, are the patient's symptoms, and that's what really matters. But we know that these other things that occur below the surface that you can see endoscopically after surgery, such as recurrent or persistent inflammation, recurrent polyps, adhesions, synechiae, middle turbinate lateralization, stenosis of the surgically created ostia, that these things under the surface really do relate to patient symptom, patient control of symptom, patient's quality of life. And, we just don't want problems like we have here on the screen with recurring polyps and scarring, and even in a non-polyp patient, lateralization, synechiae, and not so much of an open cavity. So to kind of look at where best practices can go at this point, I've chosen two very quick cases here to kind of illuminate, I think, the two ends of the spectrum for me in terms of the type of patients I treat. Now we're going to start with this patient here who has chronic sinusitis without nasal polyps. This is a 37-year-old female with mild chronic sinusitis, no polyps, but she has chronic nasal congestion. She has recurring infections with purulent mucus, mid-facial pressure. She does respond to antibiotics, but these exacerbations occur 3 to 4 times per year. And you can see here from the CAT scan that there is evidence here of some mucosal thickening. The OMC, the infundibulum's a little bit swollen, some of the adjacent ethmoids are a little bit reactive, as well as the base of the maxillary sinus here. But overall, it just doesn't look like that bad of a picture. Of course, this is below the iceberg. This is in the CT scan finding. We can't actually measure the inflammatory process here. Certainly the symptoms are quite significant. So after maximal medical therapy, I took this patient for endoscopic sinus surgery, and because I felt that there wasn't much of an inflammatory basis on the CAT scan findings, I just placed a gel film spacer just to hold that space under the middle turbinate open. And I took a look at the patient here at 10 days after surgery, and this is right after debridement and clearing that gel film out of the nose. And you can see that when we look up in the ethmoid cavity, there's edema that bridges the entire cavity. There's a hyperplastic reaction there that almost looks like an early polyp. And Samer, I would guess, I ask you at this point, are there things that we can do differently at this point, or things we should do differently to help prevent this from occurring?
Well, I mean, this is always hindsight is 20/20. Clearly, this is not, I think, what you were hoping for, and I suspect that the patient may have some symptoms at this point. If the patient has symptoms at this point, traditionally, what we would have done probably put them on to rescue them with some oral steroids. But I think, there's a learning process also with this high-dose topical therapy with the implant and all that. And we've seen some of these patients that up front have mild disease, and I agree with what you've done and the decision not to necessarily put an implant in. But I think we see so many of these, and at the end of the day, if this is kind of happening on a routine basis in your practice, then this is where your comfort zone goes up, probably, of using some high-dose topical therapy into the ethmoid cavity, because the alternative to this patient is to place them at this point, if they're symptomatic, of course, to put them on some oral prednisone. So would they have benefited from an implant or high-dose topical therapy? Probably. Would I have made the decision up front with that mild disease? Probably not. So as I said, hindsight is 20/20, but this is a difficult situation because you're dealing with mild disease and the patient later on manifested with a little bit more severity of disease than what you've expected. So difficult thing, but this is part of our learning curve, and we see some of these patients, and this is where we have to use our clinical judgment to intervene or not with the implant or high-dose topical therapy.
So just to back up a little bit, I think, we use these terms mild disease based on the fact that we're very visual, and the things that we can see in this patient, such as the endoscopy and the CAT scan, look fairly mild. But what we're unable to do in these patients is really measure that inflammatory basis. And we know from the patient's symptoms that there's a real problem here. This is not someone with mild CRS. She has significant congestion, recurring infections, but the objective findings that we have available to us are fairly limited. So I think it's hard to know just what's driving that bottom of the iceberg, what's underneath the whole process here. Well, there is clinical research that Propel benefits both patients with polyps and without polyps. So here is a patient without polyps who had a big inflammatory response present after surgery. And we can see that polyp patients have a significant reduction in the need for postoperative interventions, such as steroids, debridements, and lysis of adhesions. But we can also see that in these randomized trials, that non-polyp patients also had an equally significant reduction in need for those postoperative interventions. So I think there's evidence that this lurking inflammatory basis is equivalently treated with local topical delivery of medication. So on the very other extreme of the whole spectrum, I'm going to present a patient here who has significant polyps. And this is a 32-year-old female with severe chronic sinusitis, bad polyps, asthma, and aspirin sensitivity. Now, we used to know this as Samter's triad. It's now known as AERD, or acute exacerbated respiratory exacerbated respiratory disease. And this person has chronic progressive nasal obstruction, anosmia, surprisingly not much pain or pressure, and you can see that there's an extensive amount of hyperplastic and polyp mucosal reactivity throughout all of the paranasal sinuses. And so this patient was treated with maximal therapy, didn't get very much response, and I decided to go ahead with endoscopic sinus surgery, opening all of the sinuses. At the end of the procedure, Propel implants were placed on both sides. The patient was started right away on budesonide irrigations twice a day. But in this case, I did not use oral steroids either prior to surgery nor after surgery. And that's a bit of a break in tradition in patients with Samter's triad. But here is this particular patient. Now, not everyone looks this good, but here is this particular patient at the first initial visit after surgery, 10 days post-op, and I've debrided all of the crust and all of the blood and fibrin and mucus out of this, and you can see the sphenoid, you can see the roof of the ethmoid, you can see up into the ethmoid, into the frontal recess, and I'm really pleased with how this looks, especially in the setting of Samter's triad, because these patients are very inflamed, and often in the past I would see a lot of inflammation in these tissues, even at this first post-op visit a week and a half after surgery. So this patient was then maintained on budesonide irrigations twice a day, as well as aspirin desensitization, and fortunately did not require oral steroid courses. And here's the same patient at 6 months postoperatively, and we're looking again into the sphenoid and the ethmoid roof and up into the frontal sinus. And I'm just really, pleased with, how this patient is done. Samer, have you changed very much your approach to perioperative oral systemic steroid therapy with the additional tools we have now with local drug delivery?
Yeah, it was a process. I mean, I was a strong proponent, of course, because of the severe inflammatory disease that I see, mainly with allergic fungal and nasal polyps, of using systemic steroids perioperatively, pre and post-op. But we always, as I mentioned before, we have this love-hate relationship. I mean, they're so good in terms of how much benefit they give the patient, but they're so bad in terms of how I and patients hate them. So when we started using specifically the implant, the Propel implant, and seeing the results that we got, I started kind of changing a little bit my practice and pedaling back on the use of systemic steroids. And I started first selecting, of course, the patients with mild inflammatory disease and kind of skipping giving them oral prednisone at that point. And I started escalating further and further my patient selection to those that have moderate and maybe to a certain extent severe disease also. And I very rarely now use it actually even in polyp patients and allergic fungal rhinosinusitis. Does that mean that I would not use it on any patient at all? That's not the case, because we have to individualize patients, and there are always exceptions. There's the patient that comes in after having had multiple surgeries and very frustrating course of disease process and symptoms, and probably these are the patients that have very severe disease. These are the patients that you probably not want to skip the oral prednisone. They're very frustrated and you want to give them the best possible outcome possible. So it's individualized, but overall I've backpedaled on the use of systemic steroids perioperatively in these patients with the introduction of the implants of the Propel and the Mini Propel.
Well, I would agree with that. I think that it's important for me to say that not all of my patients look like this, and if anything, this group of Samter's triad is the most refractory and difficult to treat group, and not everyone looks like this, but But what's been surprising to me is how I do get people to this point now, and often without perioperative steroids. It's also important to say that I think these type of patients need to be very carefully monitored. You need routine surveillance, and you need to make sure that if they get any symptoms like loss of smell or stuffiness, that they come in, that you're seeing them routinely. And if these patients start to deteriorate, I'm very quick to go in with a burst of oral steroids to kind of recover them and get them back so the topicals can reach their delivery and do their trick. You know, I think the difference, though, is that I didn't used to see outcomes like this in very many of my patients with SAMTers, and in a number of patients even just routine polyps. And I think that with the good delivery of topical steroids to the cavity with this implant, we're able in some patients to actually reset that inflammation back to the pre-morbid baseline and really facilitate good healing after surgery. And we want to avoid these synechiae, we want nice open cavities. And I think that, you know, going forward, you know, looking at this concept of chronic sinusitis as an iceberg, you know, we're able to take people and navigate around these symptoms, the part we can see, the tip of the iceberg. We're able to navigate around that safely without running into the problems that lurk deep below the surface, such as significant inflammatory processes that would cause problems. Well, that's our, you know, kind of concept of where we are at this point with surgery, why we do it, and what types of practices seem to optimize the situation.